I'm just going to talk about antiretroviral therapy specifically. You know, we have several targets now for antiretroviral therapy. When I was back in the old days, in the mid 80s, really all we had were reverse transcriptase inhibitors. You know, back in the days of AZT, and for years, you know, really that's all we had. And now we're seeing more and more classes of drugs coming out. And really in '96, when the protease inhibitors came out, that was really kind of a big turning point in treatment of HIV. And the last 10 years have really kind of changed the whole face of HIV therapy, primarily because of these protease inhibitors. And I think in the next few years it'll be really exciting because we'll be seeing integrase inhibitors coming and all kinds of new fusion inhibitors and new classes of drugs for HIV, which I think will only make our treatments better and hopefully less toxic in the future. So this is just kind of a little timeline that shows kind of when drugs were licensed. I kind of need a roving microphone, I guess. But, you know, I think what's interesting is, you know, in the first 8 or 10 years of the HIV epidemic, really there were only 4 antiretrovirals that were launched. And so we were doing things like, oh, let's do AZT alone for a while, and oh, then let's combine it with something else, and how about maybe we do one for a while and then another for a while, and you know, we just kind of, but whatever we did, it wasn't really very effective for the virus. But since 1995, there have been 20 new products, and I expect that kind of launching of new products will continue over the next several years. And so I'm very hopeful that not only can we maybe get things that are easier to take, but hopefully less toxic, and you know, maybe look at new ways to deliver drugs. And I think you know, I think this is an exciting time in treatment of HIV. So this is just, you know, you don't have to remember all these little things, but kind of the lesson here is that we basically right now have 4 classes of drugs for HIV. We have nucleoside reverse transcriptase inhibitors. Oh, sorry. I was looking at you. We have nucleoside reverse transcriptase inhibitors. And, you know, what's particularly, I think, interesting about HIV drugs is, I don't have listed on here the trade names, but, you know, we have like 3 names for every HIV drug. You know, there's the generic name, and then there's the trade name, which I don't have listed, and then there's all these little letter names that we give to everything. So, you know, like you'll hear me talking about AZT and DDC and DDI, and then when you go look at your pill bottle, you know, it's not listed on there that way, but it's just kind of, you know, the way drugs kind of grow up. We sort of learn them by their kind of their chemical name first, which is what all these letters stand for. And then they get, you know, that's how we first learn about them. And then they get one of these kind of names, and then they get a trade name. So it can be very confusing. And I think one thing I wanted to share was this in your packet. I think you'll see this little visual thing here that kind of has the different drugs listed. And it has them broken down by classes, which I think is kind of helpful. So in this big yellow box down at the bottom, those are the nucleoside reverse transcriptase inhibitors, these right here. And then this kind of green section in the middle are the non-nucleoside reverse transcriptase inhibitors. And then this section in orange would be the protease inhibitors. And then kind of hidden off on the side here, the blue box is the one fusion inhibitor we have. So I don't know what kind of a learner you are. I'm sort of a visual person. So if you have questions, you know, you can kind of refer to this, and it kind of give you a picture of what the meds look like. Now, one thing's not on here is kind of how many you have to take a day, and I think that's kind of an important visual as well. But some of these you have to take, you know, 12, 18 pills a day. But I think the trend now really is going towards less pills. Many of these, like Sestiva, is only 1 pill a day, so that's very helpful, I think. So Maria mentioned I was going to talk a little bit about the indications for HIV treatment. And basically, you know, these are sort of reviewed all the time based on what kind of science comes out and what kind of big studies happen, and big panels of, much more important than me, people sit together and decide kind of when, you know, they review all the studies and they look and see, well, you know, what really, you know, when should we treat people, what kinds of things should we treat them with, and they publish guidelines, internationally used guidelines. You know, the ones that we use in the United States come from the Department of Health and Human Services. And again, they're guidelines. They're not meant to be, you know, written in stone, has to be this way for every single person, can't change it. You know, it's not like that. It's just a basic kind of guide that kind of, you know, helps us decide along with the patient, you know, what really is best in this instance. And these are sort of a fluid document. You know, they're reviewed periodically. They change at least once and sometimes a couple of times a year based on what kind of new science comes out. But like Maria said, basically if you're symptomatic, and certainly if you've had an AIDS-defining illness, that would be something, you know, that would be a place where you would want to be treated for your HIV. You know, now symptomatic can sometimes be a little iffy. You know, you may have a few symptoms but not a lot of symptoms, and so you might want to watch that for a while. But certainly if your immune system is suppressed to the point that you have developed AIDS, then you really should think about treating your HIV. I mean, that's something really important. Again, she mentioned the 350 cell number. That is kind of the number that we are looking at now in terms of the big studies that have come out. I think the trends now are sort of looking at maybe treating people a little bit earlier. And it's very interesting, having kind of been in this field for a long period of time. You know, back in the mid to late 80s, there was a lot of talk about, you know, only treating people that had an opportunistic infection. So basically really treating people that were very late in their illness. And then some studies came out and showed that that, you know, maybe we should treat people a little bit earlier and keep them from getting sick. And so then we started treating people a little bit earlier. And then protease inhibitors came out, and there was a big to-do that came out of New York. There was a big researcher, David Ho, that you may have heard of, and he did some big modeling with some guys from the Los Alamos laboratory, and they were able to, you know, they made these big equations that they put in all your T cell counts and your the number of white blood cells in your body and how much virus is in your body, and they made this big equation, and they said, well, you know, if we treated you with a protease inhibitor and fully suppressed your virus for 3.5 years, we could cure you of HIV. So then everybody got, whoa, we all got really excited. We ran home, we started treating everybody, and so we treated everybody, you know, very aggressively with protease inhibitors when they first came out. And then we found out that, well, you know, these drugs are not totally benign, and they do have side effects. And then some studies came out and showed that, well, you don't really get an advantage in terms of how long you live or what kind of complications you have. There's not really an advantage for treating you if your T cell count's between 350 and 500, or just waiting till your T cell count's less than 350. And that's kind of where this guideline has come from. Now, there is some kind of talk out there now that perhaps we may start treating people a little bit earlier. So far, the guidelines haven't changed, but I think, you know, what I'm saying, again, it's kind of a fluid thing, and the pendulum tends to swing back and forth sometimes. But this 350 number, you're right, has been sitting there for a while, and so that's kind of the number that we use. Certainly, if you have a very high viral load, like Maria said. The other thing that we really do strongly encourage is treating everyone that has HIV in pregnancy, because what we're trying to prevent is transmitting that virus to the baby. And we know that without treatment in the United States, a woman has about a 25% chance of passing that virus on to the baby. With good treatment and actively suppressing the virus and being careful around the way of delivery, we can take that risk of transmitting to the baby to 1% or less. So, I mean, it's really a dramatic improvement, and has been something that just has remarkably changed the face of HIV, especially in pediatrics. The other thing that we think about treating is somebody that has acute HIV, meaning that they just got infected with HIV, Again, I think the jury's still a little bit out on this one. We used to be very aggressive in trying to diagnose people and get them treated for acute HIV as soon as we could, hopefully trying to change the course of their HIV infection. Some of the newer studies don't necessarily say that we can do a lot of changing of the course of their HIV infection, and so that one's still kind of back and forth. But I think depending on how people present, if they've got a very severe acute HIV infection, then that probably is something that should be treated. And this is just kind of the same thing in tabular form, so I'm not going to go through it or belabor it. You can look at it in your handout. But again, if you've got AIDS or severe symptoms and you've got low T cell counts, we would definitely recommend treating that. And if you've got a T cell that's higher than 350 and a viral load that's less than 100,000, most people I think would say you would probably wait on that. Now, once you've made the decision about whether or not you want to treat your HIV infection, then the question becomes, well, what should we treat it with? And so kind of one of the most basic principles of HIV therapy is you never want to use one drug alone, because what happens is the virus can very quickly become resistant to that medicine and change and mutate, and then that medicine won't work anymore. Same thing happens if you use two drugs. We learned that kind of the hard way back in the 80s, that two drugs might work for a little while, but they don't work for very long. And so kind of the magic number that we use is at least 3 different medications for HIV. Now, they don't necessarily all have to be medications from different classes. Frequently we'll use two medicines from the nucleoside class and one from either a protease inhibitor class or a non-nucleoside class. And in fact, these are the kind of the preferred regimens in the DHHS guidelines. You can see there's a big difference in the number of pills you have to take depending on which regimen you choose. And there may be different considerations based on how the person is. If you're sicker and have a higher viral load, you might want to go with this, at least initially. But again, I think that's a decision that a person and their healthcare provider need to discuss very closely. Now, now that we say that there's a preferred regimen, certainly there's a whole bunch of different ones. There's a whole bunch of alternatives. And, again, if you don't want to use efavirenz, which is a non-nucleoside, you could substitute it with nevirapine. There are a couple of things about nevirapine that I'm going to mention in a second. And, certainly I don't want to go through every single possible regimen you can have, but just to let you know, there are a whole lot of different things that we can use to treat HIV now. There certainly is not one necessary magic bullet for everybody, but there are certainly different combinations that might be better for some people. Some people might do better on a once-a-day combination. Some people might do better on a twice-a-day combination. Somebody might have some other things in their medical history which might lead you to one thing or another. But basically the point is that you just, there are different combinations, and there's not one magic bullet for everybody. Now, the last thing I want to say is there are some combinations based on 3 nucleosides alone. So again, most people get started on 2 drugs from this class, the nucleoside class, and 1 drug from either the non-nucleoside or the protease inhibitor class. Occasionally, people will get started on 3 drugs only from this nucleoside class, and in certain instances, I think that's okay, but there are some studies that show that this particular 3 nucleoside class may not be as good for everybody, and certainly people that have very high viral loads, it may not be the best choice, and people that, and there are different ways of combining these 3 nucleosides. There are certain 3 nucleosides that may not go together very well, and I'll talk about that in a second. So again, I'm not, there's nothing it's not like you do this and then you do this and then you do this. It's a kind of a fluid movement with your healthcare provider and tailored to the individual. But there are certain things that really are not recommended. And some of those, again, are you never want to use a single drug. That's called monotherapy. You really don't ever want to use just 2 nucleosides, 2 drugs from this yellow class, because, again, we have learned that really is not very effective HIV therapy. These 2 drugs together, didanosine and tenofovir, probably should not be used together except in unusual circumstances, because there seems to be an interaction there that we don't totally have characterized yet, but people's T-cell counts really don't recover or do as well when you're on that particular combination. And again, as I said, there are a couple of 3 triple nucleoside regimens that really are not recommended, and so things to avoid. A couple other things that you really want to avoid: Sestiva or efavirenz. You don't ever want to use that in pregnancy or in women that could be pregnant, because it does cause a high incidence of side effects, particularly neural tube defects, defects of the spinal cord. So it's not a good idea to give a woman that could be or certainly is pregnant. You don't want to give her efavirenz. And nevirapine, which is another non-nucleoside, is interesting in the sense that it seems to cause more hepatitis in people, particularly in people with high T cells. And that's defined as women that have a T cell count of over 250 or men that have a T cell count of over 400. So again, if you've got a pretty high CD4 count, you probably want to avoid using nevirapine. So just a couple of words about the classes in general. I just want to give you some heads up about some of the side effects. Again, these are the nucleoside reverse transcriptase inhibitors. They work early on in the HIV replication cycle. And these are, it's interesting that I didn't capitalize the trade names. I don't know, I was just being antagonistic that day or something. But these are the drugs, like I said, that tend to have the letter names that go along with all the other names. And just as a heads up, it looks like that DDC or HIVID is probably not going to be available anymore, correct? After probably this year. And but these are the other drugs that we have, and there are a couple of them that actually have activity against hepatitis B. So people that have hepatitis B in addition to their HIV infection could get some added benefit by use of those 2 drugs. And there's a subclass of drugs in this, it's really classified as a nucleoside reverse transcriptase inhibitor, but it's really a nucleotide. And really the only difference between those 2 is how many phosphorus molecules are on the drug. But this drug does have some activity against hepatitis B, and it has the advantage that it can be dosed once a day. So specific side effects from these drugs, you can get anemic, which is low red blood cell counts from AZT or zidovudine. Oh, I guess I didn't put AZT on there. Certain of these drugs can cause nerve damage. We call those drugs the D drugs, DDI, DDC, D4T. You can look at the other page to get the other names for those. Pancreatitis, or inflammation of your pancreas, which is an organ that helps you digest food, can also be caused by these drugs. High triglycerides, which is a fat in your blood and is linked to D4T. Just a word about hypersensitivity. Hypersensitivity is actually when your body kind of builds up a reaction to the drug, and this happens with abacavir. Not very frequently. It's probably about 5% or so, and does seem to have kind of a genetic predisposition to it, but when it happens, it can be a bad thing, and your body continues to have problems, feels like a bad flu-like syndrome, kind of gets worse and worse with every dose. And sometimes if you don't recognize it or stop the medication in time, you can really get sick enough that you end up in the hospital. And the important thing to know is once you stop it, you really should never take it again, because there have been some instances of people that have a hypersensitivity to this drug, stop the medicine, take it again, and they have died. So it's again, not very common, but when it happens, it's not a good thing. There is a syndrome called lactic acidosis, which can happen with any of these drugs, tends to be a little worse with these, but lactic acidosis is when your body kind of switches to the anaerobic mode, meaning it's not using oxygen. It kind of, what happens is these drugs kind of poison, they get inside your cells and they kind of poison the mitochondria, the kind of powerhouses of your cell, and they mess up how your cell uses oxygen, and your blood gets very acidic, and it can happen very rapidly. And unfortunately, there aren't a lot of real strong, symptoms that would point you just to this. And so it's something that we always have to kind of keep in mind. Again, it's a very rare kind of thing. It doesn't happen very often, and but when it does, it's something that really needs to be recognized. So the next class of drugs are these three little green ones here, the non-nucleosides. And really there are only 3 drugs in this class, although we're looking to see, there should be a drug coming out in the next couple of years, I'm hoping, that will work against viruses that are resistant to these drugs. And probably out of these drugs, Sestiva is the one that you've heard the most about. That's the one that causes central nervous system problems, weird dreams, very vivid dreams. I've had people tell me that taking Sestiva feels kind of like a bad acid trip. The walls are kind of moving. But most of the time that gets better after about the first month, if you can stick it out that long. But there are people in whom it just doesn't really ever get better, and so we have to switch them to an alternative drug. Again, I talked a little bit about the hepatitis that you can see with nevirapine or Viramune. Rash is also very common with that drug. And then the protease inhibitors. Again, this is a class that's really sort of proliferating now. We have a whole bunch of protease inhibitors, and we just had one licensed earlier this year. And I expect that there will be more protease inhibitors kind of coming. The important thing to know is that here's all the different names of them. Pripranavir is the newest one that just came up. Actavis is the other name. Sequinavir was the first one licensed way back in '97, I think. We will be not seeing the Softgel Fortivase anymore after this year. I have to look over to my Roche friends all the time. And there is a new Invarase pill, which I think is reflected on here. It used to be that you had to take those a whole bunch of times a day, but now they've kind of made that so it's a lot easier. Most of these drugs you do have to take twice a day, except for Reataz, which only has to be taken once a day. Particular issues related to the protease inhibitors. Kidney stones are common with both Indinavir and, with Indinavir. You can get diarrhea with almost all of them. I mean, almost as a kind of a class of drugs, these drugs tend to cause a lot of stomach upset, diarrhea, nausea, that kind of stuff. Very common with this whole class of drugs. Dyspepsia, or kind of stomach upset, heartburn kind of stuff, again, very common. Rash we see occasionally, not quite as frequently as with the non-nucleosides. Hyperbilirubinemia. Your bilirubin is the pigment in your blood that makes you look yellow. Like when you have hepatitis, it's what causes jaundice. That can be a side effect of both of these drugs, atazanavir and Indinavir. Generally doesn't mean you necessarily need to stop the drug unless you're like really glowing and it's bothering you, which can be problematic. But most of the time they don't do a whole lot of damage to your liver, but that is one of the things that we're following. Like Maria said, we do like to check your liver frequently. I'm not going to talk a lot about these complications because I think Dr. Beers is going to talk about a lot of this, but just to mention briefly, this fat redistribution syndrome, well, I guess we don't really call it redistribution anymore because you actually lose fat in certain parts of your body and gain fat in other parts of your body. And I think you're going to talk about that a little more, right? Okay, so I'll skip that slide. Again, I think we're moving, kind of gone are the days when we used to have to tell people I mean, I'll really date myself now, because when AZT first came out, we used to tell people, you have to take this pill every 4 hours. You have to get up in the middle of the night. You have to set your alarm clock for midnight and 4 a.m. and 8 a.m. And, you know, I mean, people really stuck with that, and, you know, God bless them, because that's a really hard thing to do. And, you know, and then the next iteration of that was, you know, you have to take your Crixivan on an empty stomach with 2 huge glasses of water, and, you know, keep drinking. You can't, and there are other pills you have to take with food. And so, you know, there was a potential that you would be taking things like 24 pills a day at 5 different times of the day, and it's like your whole life was just sort of revolving around taking these pills. And things have really changed in the last few years, and now we're to the point that, you know, we have all of these once-a-day options for people. You know, we have combinations that are 2 pills once a day. Very easy. I just spoke with somebody on the phone today who said, you know, I take these pills and I've been doing these for 6 years, and it's like I don't even notice that I'm doing them anymore. He takes 2 pills twice a day, that's it, you know. And it's so integrated into his life that he can't even tell the difference. And, you know, that's really what we're aiming for. We really don't want people's lives to have to revolve around taking pills. We really would like people to be able to live their lives without any side effects from the pills, do better, feel better, and you know, I mean, that's really our goal. Last thing I want to talk about, am I running out of time? Is entry inhibitors. There's kind of a couple things in the entry inhibitor class. The one that we have licensed now is this drug in blue called Fusion, or T20. It's actually not that new anymore. It's been around for a couple of years. What it does is it actually inhibits when if you recall back to my slide at the beginning, it inhibits when the virus sticks onto the cell, when the cell membrane and the virus membrane actually fuse together. It inhibits that process. And it's a great drug. I mean, it is very good for virus that is resistant to other drugs that we have. The downside of it is that it has to be injected, and it has to be injected twice a day, and it has to be mixed up before you inject it, and you can't mix up a whole bunch of doses ahead of time. And Tony knows everything there is to know about Fusion, so I won't pretend to go there. But you know, it really can cause problems at the place where you inject it. And it's just not an easy drug to take. You know, I mean, you can imagine what it would be like to have to inject something twice a day, all the time, every day, you know, travel with it, go places, you know. And these are the places that people generally inject. You know, they kind of have to move it around, because if you get an injection site reaction to it, it can be very uncomfortable, you know, hard and painful and red, and, you know, it doesn't lend itself to a bikini very well, you know. Of course, that may not be, for me, that would be a big deal, but. Other than injection site reactions, there aren't a whole lot of side effects from this drug. There does seem to be an increased risk of bacterial pneumonia associated with use of this drug. And there's kind of a hypersensitivity thing where people feel very fatigued and they can get joint pain, and it just really doesn't help their quality of life to be on this drug. So it is one thing that we watch for. But it doesn't seem to be too hard on your liver or your kidneys or any of those kinds of things. Now, the other kind of fusion inhibitor, well, it's not a fusion inhibitor, but the other kind of entry inhibitors that we are looking at now are these coreceptor inhibitors. And did you talk about coreceptors before I got here? No. Okay. So I actually have some groovy little slides that are coming up in a minute that kind of show how coreceptors work. But what coreceptors are you know, you need a CD4 receptor for the HIV to attach onto your cell. But that's not all you need. You need these things called coreceptors in order for the HIV to really be able to infect the cell. And these 2 coreceptors that we're looking at right now are called CCR5 and CXCR4. And you know what, I think I'm going to show you those slides now, because I think, well, no, let me talk about it for a minute first. And the kinds of virus that people have tends to either be a CCR5 tropic virus, is what we call it, meaning that it likes to latch on to CD4 cells that have this particular coreceptor, or the HIV likes to latch on to cells that have this particular coreceptor. And sometimes people have both kinds of virus, and sometimes people have only one or the other. But that is something that we are going to, I think you're going to start increasingly hearing about that in HIV disease. What kind of tropism does your virus have? And that is something that right now we can't like commercially test for that. Like if somebody comes to my office and says, I want to know what kind of tropic virus I have, I can't really do that. But that is part of a research study, and I think will become more available as time comes on. There are 3 drugs in this class so far. There's a Plavarac, Vicrivarac, which have been taken out of development. One because it doesn't work very well, and another because it was very toxic to people's liver. But the drug of this class that is still in development is Miravirac. It is moving through the process. It's being tested now. The thing that I would say about all 3 of these drugs is that they are specifically CCR5 inhibitors. So they don't really work, well, we don't think they really work very well against virus that uses CXCR4 as a co-receptor. So again, that's, I think, what you're going to be hearing in the future. People are going to be sort of typing their HIV to see whether or not these drugs would work. Okay, so here are my groovy little slides that kind of show, probably do after this one. So this is kind of a little cartoon about how HIV attaches to a receptor and how some of these entry inhibitors, specifically CCR5 inhibitors, work. So if you can imagine that this whole gray thing is a CD4 cell, and these little yellow thingies would be, we'll just call this the CCR5 co-receptor, and we'll call this the CXCR4 co-receptor. So this cell would actually be, would have both co-receptors. Okay, so if this is your cell all ready to be infected, that whole thing is the complex. Here comes the HIV. It kind of looks like the mothership, you know, but it's kind of coming down, and this is the little thing that sticks out of the side of the HIV. This is called the GP120, and this is the piece of, like, there's a whole bunch of these all around the outside of the HIV, and these things are the things that stick into the receptor. So it's lining up here, it's getting ready to attach to the receptor, and what happens is this piece attaches to the CD4 receptor, and then these little green doohickeys attached to the CCR5 co-receptor. So you really need both of those pieces of things to happen, and then the cell membranes can fuse. This is the HIV cell membrane, and this is the CD4 cell membrane, and then all the RNA from the HIV can get injected into the CD4 cell, and that's what causes the infection. So you really need that whole kind of, it's kind of a science fiction kind of process. I mean, it's amazing that people figure this out. But you need that whole thing to happen in order to get a productive HIV infection. So then what happens if you have a CCR5 inhibitor on board, let's say. So let's say this little cute little butterfly looking thing is a CCR5 inhibitor, one of this new class of drugs, Miravirac, I guess is the only one we have around now, floating around in your bloodstream. It will actually attach here to your CCR5 co-receptor, and then when the nasty mothership comes to try and land, it can't get there. These little green things can't attach because the configuration of the CCR5 inhibitor has been changed. And so this piece might be able to attach, but down here that piece can't attach. And so fly away, it won't get infected. So that's the most, in the best of all possible worlds, hopefully that's the way this drug will work without any side effects, and you only have to take it once a day, and it'll really be cheap, and Pollyanna. But, again, it's sort of the mechanism of action of how it works. Actually, I will just say 2 quick words about drug resistance, and then I will just stop. So I talked a lot about how we do initial drug tests or initial drug regimens, but then what happens after, say, the first combination of meds stops working? Well, then what we do, and this is actually a new development that's come up in the last 3 or 4 years, is we are now able to actually, well, actually maybe 5 or 6 years, we're able to test the HIV to see what kind of drugs work. And there's actually 2 different tests that we use. We use genotyping, which gives you the whole long string of the genetic material in the virus and tells you where it has changed, and because of these changes, which drug doesn't work anymore. And there's phenotypic resistance testing, which actually involves taking a person's HIV, putting it in a kind of a cell culture with a bunch of different combinations of drugs and seeing which drugs will work. Now, what we generally use almost all the time is genotyping, because it gives us a lot of good information. It costs less, it's faster to perform, it's done in a lot of different labs. Phenotyping is good in some situations, but it's really only done in a few labs, and it costs about 4 times as much. So if you have any more questions, I'll be happy to answer them, and then here's some websites that you guys can look up things. So thank you. Thank you.